this lesson, we're going to review an evidence-based model of care called CAPABLE, Community Aging in Place, Advancing Better Living for Elders, and understand how it was adapted to fit in the waiver for My Choice participants. Then we'll review a participant story. So the objectives for this lesson are to review the problem of poor function experienced by all My Choice participants, and then the solution, use of an evidence-based model of care. So the problem is that 42% of older adults report a problem with function, which is usually called disability. And the number of disabled are increasing rapidly, primarily due to the obesity epidemic and chronic conditions. We know problems with function can lead to inability to carry out everyday activities of daily living, like bathing, dressing, eating, walking, and shopping. And we also know that problems with function can lead to falls, poor quality of life, and nursing home placement. These points are particularly true for My Choice participants. So here's a checkpoint. True or false? Many older adults report a problem with function and disability. The correct answer is true. So one evidence-based solution in this global healthcare problem is the model of care called CAPABLE. In 2004, CAPABLE, which started as ABLE, was 6 home visits conducted by a combination of OTs and PTs, had some home modification. At that time, the clinicians addressed function and home safety. ABLE reduced functional difficulty, improved home safety, and helped people carry out ADLs and IADLs. Then in 2010, ABLE was extended to CAPABLE and was modified to include 6 OT visits to address function and fit in the home setting, and 4 RN home visits to address pain, mood, medications, strength and balance, and PCP communication. A pharmacist was also conducted medication review, and home repairs or modifications were made as needed. Then in 2014, CAPABLE was extended to My Choice in Michigan and adapted for Medicaid participants, adding OT home visits and social work to the overall care model. 10 home visits were tailored to the needs of My Choice participants. RNs were trained to use an app to review medications, and home repair and modifications followed the usual rule, being medically necessary. Then from 2015 to 2018, we pilot tested use of CAPABLE in 4 My Choice waiver sites located in Flint, Saginaw, Detroit, and Grand Rapids. So CAPABLE is guided by the disablement process, focusing on individual and environmental factors that influence disability to increase the person-environment fit. And also the lifespan theory of control, focusing on chronic conditions that lead to poor health and loss of control. CAPABLE specifically focuses on increasing control and decreasing factors that undermine control, such as pain and depression, and also modifying the environment to increase physical control. It's also supported by the Zanton-Gill resilience model, which focuses on physiological, individual, environmental, community stressors that might affect resilience. The belief is that building resilience will support the ability to control factors influencing disability. The model is participant-driven, asking and listening to the desire of the person, evaluating readiness to change, and consulting, not treating and telling what to do, through an interview and observation process. The model is culturally relevant, understanding where the person's coming from, their life experience, through reflecting. The model is problem solving to help to name an issue or cause and finding ways to solve the problems using teamwork and brainstorming. The model is customized, a tailored approach unique to the person and their environment through a person-centered service plan. And the model is active engagement with the participant involved in learning new strategies through clinician demonstration and role-playing and practicing. And then modifying the plan is needed. The model is interprofessional with 3 disciplines: RNs, OTs, and social workers. The model works on the person-environment fit, tailoring the home around the person's needs. The model is preventative, working to improve function. Here's another checkpoint. How does capable enhance function in older or disabled adults? Is it person-centered care that's self-directed by the participant to meet their desires and goals of the person? Is it focused assessment to tailor and individualize care? Is it interdisciplinary, social worker, RN, and OT, and coordinated care based on the needs of the individual? Is it medication review and management to minimize contraindicated side effects or duplicative drugs? Or is it all of the above? The correct answer to this is all of the above. Thus, the model focuses on enhancing function through a systematic, focused assessment that drives individually tailored care. It's often used in nursing facility transitions, new admits to my choice, or those that are just discharged from the hospital, or after a fall when there's a decline in function. The model motivates a participant to improve function or problems that influence function. The model is provided for up to over 36 weeks and includes a short increase in the number of home visits needed by the participant. This could be 1 to 4 additional RN visits, 1 to 6 OT visits, and or 1 or 2 additional social work visits, in addition to the usual My Choice supports coordination care. And, of course, interdisciplinary coordination occurs to discuss the plan. The RN also reviews the medication and works with the PCP to modify the medication profile as needed. Modifications are made to the environment to increase the physical control along with equipment to supplement any identified needs. This is a list of principles you as a clinician will need to provide an evidence-based model of care. Person-environment fit is focused on how the home environment where the participant lives is fit for usability to improve their function for ADLs and IADLs. The person-centered self-directed care is structured in a way to elicit the participant's desires and needs. And then building a collaborative relationship is the intentional building of trust with the participant and their caregivers. And building of self-efficacy regarding the power a participant actually has to face challenges competently, and the choices a participant is most likely to make. So this is a list of approaches you as a clinician will use to provide an evidence-based model of care. Readiness to change assesses a participant's willingness to use new ways of carrying out valued daily activities, while motivational interviewing techniques encourage participants' use of strategies to manage at home. Cognitive behavioral therapy, a short-term goal-oriented focus on how thoughts and feelings impact behavior, is also used. And then brainstorming, a group discussion to produce ideas and ways of solving problems, Problem solving, which is a group discussion to produce ideas and ways of solving problems, working through details of a problem to reach a solution. And role modeling, a clinician by a clinician, so that the person who serves as an example for the participant by demonstrating behavior associated with a particular role the participant or caregiver needs to copy. So this is a list of techniques you as a clinician will use to provide the evidence-based model of care. Communication is a two-way process. You exchange thoughts, feelings, or ideas towards a mutual goal and collaboration in the process of two or more people or organizations working together to realize or achieve something successful. Whereas reflection is serious thought or consideration, thinking about experiences or examination of personal thoughts and actions. And interdisciplinary coordination is with all members of the team, including the participant, working together to help attain the participant's desires or needs. With Capable model, there are 4 phases of care. Assessment of the participant, their situation, the home environment, and readiness to change. And then the person-centered service plan, where you problem solve and collaborate on development of a plan and expected outcomes, and then jointly select strategies to be enacted within the plan. And then there's the enactment of the strategies, where the participant uses them to improve, and the clinician role models how the participant and caregiver can use them. And then strategies are evaluated and modified as needed, and sometimes we have to select new strategies. And here's another checkpoint. The phases of care in Capable include assessment of the person, environment, plan of care, and role modeling, or assess, plan, and instruct, or assess, coordinate care, and review. And the correct answer is assessment of the person and environment, a plan of care, and role modeling. So here's what the clinicians do. The RN assesses pain, strength and balance, medications, risk of falls, incontinence, and presents strategies to self-manage, and coordinates with the team and reviews the medications and adjusts them with the PCP as needed. The OT assesses and observes ADLs and IADLs and presents strategies to self-manage at home and, if needed, obtains equipment or home modifications. And the social worker does a complete mood assessment if needed and addresses depression, family dynamics, and mental health issues, and of course, always focuses on community resources. So you're probably wondering what is different about this model of care than what is already occurring in the My Choice program. Here's what an RN who had worked in My Choice for over 5 years then was trained in this evidence-based model of care said. The model enhances My Choice and stops the risk of people going back to either a nursing home or the hospital. We had some education in My Choice, but use of evidence enhances what we already know to prevent decline in participants from happening. And it enhances how we listen to the participant, providing them with what they desire, motivating them or giving them the tools, like a useful piece of equipment, to reach the goal that they want. Here's another example from an OT that was trained in use of this evidence-based model of care. It's like an add-on to the waiver. and it actually fills in the gap when waiver's not there. And it teaches people, because the ultimate goal of the waiver is to allow seniors to stay in their homes, and it just addressed the needs, the missing gap. We come in, we work with them, and understand what their barriers are and what we can do, teaching moments, and using community resources. And here's what a social worker who had worked in My Choice for over 10 years and was trained in the evidence-based model of care said. Drawing on the training, having conversations with participants about how they want to improve their lives, and then connecting the participant with resources to help them do that. The timing of delivery of an evidence-based model of care that's person-centered and based on the needs and desires of the participant is the goal. The model of care is flexible and changes as needs or desired, with visits earlier or later than planned. All elements of care do not need to be provided unless desired by the participant. In sum, all care when using this model is adjusted or tailored based on the participant's needs and desires. In the pilot project previously mentioned, we cared for 270 My Choice participants at the 4 waiver sites. We did an average of 4.3 OT visits, 3.1 RN visits, and 1.8 social work home visits, in addition to the usual supports coordination over 20 weeks. We found 83% of the participants had medication reviews conducted by the RN. The average number of medications taken were 18, prescribed by 8 different doctors. We found in our pilot project that use of an evidence-based model of care improved ADLs and IADLs and reduced falls in the number of hospitalizations. In addition, 95% of the participants who received care felt the care helped them to stay at home. Here are a couple of statements from participants who had received care. Remember, they also received My Choice care, and in these 2 cases, one had been in My Choice for 5 years and the other person for 7 years prior to receiving this evidence-based model of care approach. One person stated, "Care improved my ability to bathe and make meals, so my caregiver could get a job and her daughter back from foster care." Another stated, "Since I started care, I feel more independent because I have the strength and ability to care for myself." So here's another checkpoint. What happened when capable was used in My Choice? Were there fewer falls, fewer hospitalizations, improved function, or all of the above? The correct answer is all of the above. So here's a case study of a real-life My Choice participant who had received the evidence-based model of care during our pilot study. Prior to receiving the evidence-based model of care, this participant had been in the My Choice program over 8 years. This was a 56-year-old female who lived alone in a house. She had a history of COPD, diabetes, CVA with right-sided weakness, polio, coronary artery disease, and hypertension. On assessment, she was able to perform ADLs but had great difficulty with bathing, transferring, and ambulating due to her right-sided weakness. She was very close with her mother, who had recently died, but had little or no contact with her brother or sisters since her mother's death. She was feeling like her children had forgotten her. Often, she feels alone and depressed. She reported praying for God to take me now, but denied thoughts of suicide. Her goals were to improve her ability to bathe, transfer, ambulate, and elevate her mood. The focus of her person-centered service plan was to obtain assistive devices for fall prevention, to improve her ADL tasks, diet choices, and mood. She also needed lawn service. There were also unresolved issues with her property taxes that impacted her mood. To you, these may seem like needs that would have been addressed in the My Choice program, but notably, she had been in the program over 8 years and was not receiving these supports. Here is a list of assistive devices obtained. A non-slip grip for $17.43, which was installed at home, the home side entrance, because she wanted to feel more secure entering and exiting the home. To prevent falls, the OT obtained a reacher for $25.42. She felt safer at home and fall risk was reduced. Each of these could have been done previously while in My Choice and were not. To improve her ADL tasks, the OT had a grab bar installed by the bathtub for $100. After it was installed, she was able to safely enter and exit the bathtub and bathe independently. Before installation of the grab bars, she could not perform independently while bathing. And please note again, the grab bars could have been installed previously in the My Choice program. Regarding improving her mood, working with the social worker, she was encouraged to attend social activities and eventually reported going out of the house more often with her favorite aide. She now goes out shopping and socializes frequently, getting out of the house. She also talked and wrote about her feelings and was encouraged to talk about feelings during visits with the social worker. Overall, she was feeling happier. Again, this could have been done previously with the My Choice social worker. She also needed lawn services, so the social worker coordinated and had both snow removal and lawn care provided, and she was happy with both. Sounds like a broken record, but again, she could have had this all done previously in My Choice. She also needed improved diet choices as she was a type 2 diabetic. She was provided a healthy food choice list for a type 2 diabetic, and the RN worked with her to meet her diabetic knowledge deficit needs. Within 3 months, her blood sugar levels were within normal limits, and she was feeling healthier and had more energy. The social worker also worked with her to resolve issues with property taxes from past years. The social worker sent copies of receipts and invoices showing taxes owed to the county, and the discrepancy with the amount owed was identified. The problem was resolved after the social worker assisted. This was a highly satisfied participant, as the evidence-based model of care was used by both the OT, RN, and social worker on home visits to improve the quality of her life. Here is what she said. She was sad that Capable ended and wished it was longer. This was a very helpful program. The visits were very helpful for my everyday life. The workers cared about me. The information was very helpful, and I keep all of it so I can reread it if necessary. She was satisfied with the content, the clinicians, and the timing of care. In summary, an evidence-based model of care that is person-centered and self-directed way of caring for My Choice participants can be highly effective. When care is focused on the desire of the participant, that is what occurs. This case provided an example of how even though the individual had been cared for in My Choice for over 8 years, this evidence-based model of care that was person-centered and self-directed made a difference in her life. In conclusion, an evidence-based model of care is a solution to help improve or maintain function in My Choice participants, so they can remain living in the community where they most want to be. Next, there are several lessons and readings for you so that you could become certified in providing this evidence-based model of care. Everyone goes through this certification program at a different rate, and it can take between 2 and 4 hours, and you can start and stop as needed. As we all know, you're very busy. Thank you.